Hello, my name is Babette Langeneckert. I'm a Senior Data Coordinator, Education Coordinator at the Missouri Cancer Registry and Research Center. This presentation's slides were created by Lucinda Ham, Senior Health Program Specialist. This presentation will cover the Solid Tumor Rules for other sites. First, I'd like to acknowledge the Missouri Cancer Registry and Research Center is housed on the campus of the University of Missouri in Columbia, Missouri. The Missouri Cancer Registry and Research Center is supported in part by a cooperative agreement between the Centers for Disease Control and Prevention and Missouri Department of Health and Senior Services, and a surveillance contract between DHSS and the University of Missouri. Missouri is also a research state for SEER. There were a lot of changes to the 2024 update to the Solid Tumor Rules other sites. For all cases that fall into the other chapter, use the 2024 update for all cases diagnosed January 1st, 2023 and after. If unsure about which set of rules you should use, go to the beginning of the chapter, which will tell you which MPH rules to use. Use the rules that apply to the most current tumor to determine new primaries. Many changes were made to the other chapter and can be found in the 2024 revision history. The other chapter is used for any sites that do not have its own solid tumor rule. Changes from the 2007 MPH rules. The previous 2007 MPH rules instructed you to code histology from the most representative specimen. For all sites included in the 2023 Solid Tumor Rules other sites, the instruction is now to code the most specific histology from biopsy or resection. When there is discrepancy between biopsy and resection, that is, two different histologies, code the histology from the most representative specimen, greater amount of tumor. Instead of adding numerous site-based histology rules to the 2023 revision, the histology tables will include additional coding instructions and notes to assign the correct ICDO code. Each histology table may include coding tips specific to that site. Not all sites are included in the tables. Rectum and rectal sigmoid are included in the colon rules. Do not code under other sites. There are a couple equivalent terms to pay attention to. Acinar adenocarcinoma of the prostate is equivalent to adenocarcinoma. It should be coded 8140. And with, as in duct and lobular, is equivalent to duct with lobular. The words and with are used as synonyms when describing multiple histologies within a single tumor. Basal cell carcinoma and basal cell adenocarcinoma are equivalent in prostate primaries only. Both of these histologies are coded 8147. Carcinoma is not the same as adenocarcinoma unless defined by a specific modifier, such as serous. Both are coded 8441. In situ is equivalent to non-invasive or intraepithelial. The rest of the equivalent terms on this list are pretty straightforward. Equivalent or equal terms continued. The terms tumor, mass, lesion, and neoplasm are not used in a standard manner in clinical diagnoses, scans, or consults. Disregard the terms unless there is a physician's statement that this is malignant or cancer. These terms are used only to determine multiple primaries. Do not use these terms for case finding or determining reportability. Terms that are not equivalent are equal. Bilateral is not equivalent to either single or multiple primaries. Carcinoma NOS is not equivalent to adenocarcinoma NOS. Component is not equivalent to subtype, type, or variant. Component is only coded when the pathologist specifies the component as a second carcinoma or sarcoma. Now we'll do a quiz. Each of these statements are either true or false. Number 1, when there is discrepancy between the biopsy and resection, the histology is coded to the more definitive specimen. 2, serosa equals visceral peritoneum. 3, in situ equals intraepithelial. And 4, bilateral is equal to multiple primaries. Quiz 1 answers. Number 1, when there is a discrepancy between the histology on the biopsy and the histology on the resection, code histology for the more definitive specimen is false. This is a bit of a tricky question. Per the rules, you code the most specific histology from biopsy or resection. When there is a discrepancy between the biopsy and resection, two distinctly different histologies, code the most representative specimen, the greater amount of tumor. Number 2, serosa equals visceral peritoneum is true. Number 3, in situ equals intraepithelial is true. And number 4, bilateral is equal to multiple primaries is false. This is the Other Sites Table Index. Click on the table to direct you to the primary site you are working on. Table 1 shows paired organs and sites with laterality. Table 2 shows mixed and combination codes. Tables 9A, 22, and 23 were just added in 2024. These tables can be used for cases diagnosed January 1st, 2023 and forward, even though they were just added in 2024. Table 9A provides new guidelines for assigning primary sites for liver and intrahepatic bile duct neoplasms based on histology and other criteria. New for 2024, guidelines for assigning primary sites for liver and intrahepatic bile duct neoplasms based on histology and other criteria are included in the newly added Table 9A. The new criteria for coding liver versus intrahepatic bile duct is based on Cancer Path Chart Specialty Matter Expert Review. The experts have determined adenocarcinoma and subtypes of adenocarcinoma cannot be primary to liver and therefore are biologically impossible. The coding instructions in Table 9A may be applied to cases diagnosed 2023 and forward. This is part of Table 9A in the Solid Tumor Rules Other Sites. These guidelines for assigning primary site for liver and intrahepatic bile duct was added in 2024, but you can use them for cases diagnosed 2023 and forward. If you have a biopsy or final aspiration of the liver, a pathology or cytology diagnosis of adenocarcinoma, and supporting documentation such as scans, lab tests, or there is a definitive clinical diagnosis of an intrahepatic bile duct primary, code the primary site as C22.1, intrahepatic bile duct, and the histology as 8160, cholangiocarcinoma.
If there is no documentation supporting the primary site of intrahepatic bile duct in the medical record, code primary site to C80.9, unknown primary, and histology to 8140, adenocarcinoma. Now we'll do another quiz. A patient presents with right upper abdominal pain and jaundice. On January 10, 2024, a CT of the abdomen showed an intrahepatic mass in segment 5. No other abnormalities were noted. A fine needle aspiration of the liver is positive for adenocarcinoma. What is the primary site? And what is the histology? The primary site would be C22.1, intrahepatic bile duct, and histology would be 8160, bile duct carcinoma, or cholangiocarcinoma. Here's another quiz. Patient has history of colon cancer, and CT of the abdomen showed an intrahepatic mass in segment 5. No other abnormalities noted. On January 10, 2023, a fine needle aspiration of liver is positive for adenocarcinoma. The managing physician stated that this is either a bile duct primary or mets from the colon cancer. What is the primary site? And what is the histology? For this case, the primary site would be C80.9, unknown primary, and the histology would be 8140, adenocarcinoma, NOS. Now we'll go over some of the tables for the Solid Tumor Rules other sites. Table 1 is a list of paired organs with laterality. Laterality must be coded for all sites listed on this table. And note, SEER does not allow coding laterality for other sites not listed. The paired sites have changed slightly over the years. This list is for sites in the other chapter only. These are additional paired organs in which laterality is coded. Table 2, Other Sites, Mixed and Combination Codes. Here are some notes for mixed or combination codes. Note 1 says not to use Table 2 for determining tumor histology when both invasive and in situ behavior is present, or when one histology is described as differentiation or features. Note 2 says some combinations can be either in situ or invasive. And note 3 reminds us that this table is not a complete listing of histology combinations. This is Table 12 for thyroid. Column 1 contains specific and NOS histology terms. Specific histology terms do not have subtypes variants. NOS histology terms do have subtypes variants. Column 2 contains synonyms for specific or NOS terms. Synonyms have the same histology code as the specific or NOS term. Column 3 contains subtypes variants of the NOS histology. Subtypes variants do not have the same histology code as the NOS term. The vast majority of cases are going to be a single tumor with a single histology. A single tumor is always a single primary. It gets tricky when a person has multiple primaries. For example, if a patient was diagnosed with a tumor in 2018 and now has the same tumor, is it a new primary or is it considered a reoccurrence? Follow the rules to determine if a case is a new primary. Rules M3 to M5 are site-specific for prostate and retinoblastoma for the eyes. For example, Rule M4 states to abstract multiple primaries when the patient has a subsequent small cell carcinoma of the prostate more than 1 year following a diagnosis of acinar adenocarcinoma and or subtype variant of adenocarcinoma. Rules M6 to M8 are also site-specific. Rule M6, Kaposi sarcoma of any site is always a single primary. Rule M7 indicates a single primary for follicular and papillary tumors in the thyroid diagnosed within 60 days. On the other hand, Rule M8 tells us that anaplastic carcinoma of the thyroid and another histology are two primaries, requiring two abstracts. Rule M9, bilateral epithelial tumors of ovary within 60 days are a single primary. Tumors must be the same histology or be an NOS subtype variant. Rule M10, tumors on both sides, right and left of a paired site listed in Table 1 are multiple primaries. If, for example, you have both a right and left fallopian tube, since it is a paired organ, this is multiple primaries. Rule M11, adenocarcinoma in Adenomatous polyposis coli, familial polyposis, with one or more in situ or malignant polyps is a single primary. Note, tumors may be present in a single or multiple segments of the small bowel, colon, rectal sigmoid, or rectum. Rule M12 is a timing rule. Every site has a timing rule. For all the sites in the other sites chapter, the rule is 1 year. Rules M13 and M14 tell us when to create multiple abstracts based on the site codes. The sites listed: anus and anal canal, C21, bones and joints, C40 to C41, connective subcutaneous and other soft tissues, C49, and skin, C44, are always multiple primaries if the fourth character in the ICD-10 code is different. Rules M15 and M16 are for coding polyps. Rules M17 to M19 are based on the tables. Review your case to determine which rule would apply. If you're a new registrar, start with the module that applies, such as multiple tumors or single tumor. If you have a case that does not meet any of the above criteria, follow Rule M21 and abstract a single primary. Now we'll go over the other sites' histology coding rules. Use Rule H1 only when no pathology report is available. Rule H2 is the rule that is used most of the time. Reportability of squamous intraepithelial may vary by site. For example, CIN3 of the cervix is not reportable to any of the standard setters. CIN of other sites may be. There may also be differences in reportability by standard setter. This list should not be used to determine reportability. Rule H3 covers when to use code 8077/2 for the intraepithelial neoplasia of the anus, AIN, vagina, VAIN, etc. Rule H3 can be tricky, as some of the histologies in this list are not reportable. State requirements may vary on the state standard setter, NPCR or SEER. For example, CIN with severe dysplasia is not reportable in Missouri, as we are an MPCR state. Note 8077 cannot be used for glandular intraepithelial neoplasia, such as pancreatic. Rule H4 is for glandular epithelial neoplasia. That is your pancreatic intraepithelial neoplasia, high-grade biliary intraepithelial neoplasia, esophageal intraepithelial neoplasia, etc. Rule H5. This is a very important rule with changes for cases diagnosed January 1st, 2023. Rule H5 instructs us to use 8210, 8261, or 8263 when the final diagnosis is adenocarcinoma or carcinoma in one of the different types of polyps. In order to code 8210, 8261, or 8263, it must meet one of these requirements. If the final diagnosis indicates histology other than adenocarcinoma or carcinoma arising in a polyp, code the specific histology. This applies to all sites. For example, an endometrial biopsy showed endometrioid adenocarcinoma in situ arising in a polyp. Code endometrioid adenocarcinoma in situ. Rule H6 tells us to code the subtype or variant when an NOS histology and a single subtype or variant of the NOS code is present. For example, adenocarcinoma in situ NOS and a specific in situ adenocarcinoma would be coded to the more specific subtype. Rule H7 refers us back to Table 2 for coding combination codes. The SEER inquiry system is a great resource for looking up unusual coding combinations. If nothing is posted about your scenario, then you can ask a SEER registrar for coding advice. The next section of the histology coding rules is for a single tumor with invasive and in situ components. There's only one rule, Rule H8. When both components exist, always code the invasive component. Rule H9. When there is no pathology or cytology report available, you code the histology documented by the physician. Just make sure you document this in your text. For example, put in your text, per hem-onc, note, May 2nd, 2022, patient with newly diagnosed acinar adenocarcinoma of the right upper lobe lung. This is so your QA reviewer or state registry knows where you came up with the histology. Rule H10 tells us to code the histology from a metastatic site when there is no pathology or cytology from the primary site. Rule H11 is specifically for adenocarcinoma NOS of the prostate. If any of these histologies are documented, the correct histology is 8140. Rule H12 tells us to code the histology when only one histologic type is identified. Do not code terms that are not listed in the histology description. Use tables 3 to 23 to find the correct histology type when compound terms are combined into a single code. For example, myxoid pleomorphic liposarcoma has more than one histology term listed and is coded 8854/3. Rule H13 addresses histology codes for polyps. Rule H14 is specifically for pancreatic primaries and how to code subtype variants when the diagnosis is ductal carcinoma or adenocarcinoma. Rule H15 is similar to Rule H6 for in situ tumors. Code the subtype or variant when there is an NOS and a single subtype or variant of that NOS. For example, melanoma NOS is coded 8720. If the pathology report states it is melanoma superficial spreading, then you would code it to the subtype 8743 for superficial spreading. Refer to the tables for subtype or variants of other sites. Rule H16 is new for 2023. This rule instructs us to code anaplastic carcinoma of the thyroid 8021 or undifferentiated carcinoma of the thyroid 8020 when other thyroid histologies are present in a single tumor. Rule H17 addresses the differentiated carcinoma 8020. The differentiated carcinoma is a distinct histology which has a worse prognosis than endometrioid adenocarcinoma. Code the differentiated carcinoma 8020 when mixed with endometrioid carcinoma or adenocarcinoma. Rule H18 is specific to thyroid primaries. Often in the pathology for thyroid cases, you will see papillary carcinoma. This is code 8050. But this rule is telling you for thyroid primaries, papillary carcinoma and papillary adenocarcinoma are both coded to 8260. Rule H19 is specific for thyroid primaries as well. The term micropapillary and papillary microcarcinoma does not refer to a specific histologic type. Rule H20 is another rule specific to thyroid primaries. Code 8340 when there are multiple papillary and follicular variants of the thyroid. A few examples are papillary thyroid carcinoma NOS and follicular carcinoma, or papillary carcinoma, a follicular variant, and follicular carcinoma. Rule H21 is dealing with combination codes when there are multiple histologies. This rule refers you to use Table 2 in the site-specific tables 3 to 23, or when you receive a combination code from Ask a SEER registrar. Rule H28 tells us to code the histology of the underlying tumor when there is an extramammary Paget's disease and an underlying tumor of the anus, perianal region, or vulva. These were the resources used for making this video. This concludes this video on the Solid Tumor Rules other sites. If you have any questions, please contact the Missouri Cancer Registry and Research Center at one of these numbers, 573-882-7775 or 1-800-392-2829. Thank you.